Thank you, Arnold, for keeping us all on time. I am going to frame this presentation on the basis of some questions that we're often asked by patients about gene therapy studies that are ongoing at our institution, both in Pompe disease and Duchenne muscular dystrophy. The University of Florida is actually where AAV vectors were discovered now 30 years ago. I moved there from Baltimore at the time we first described the use of AAV as a way of delivering gene therapy vectors to muscle. And so I thought I'd at least start by repeating some of the basics so that we're all on the same page. So what is AAV and how are they delivered? So this is a parvovirus, even though the name gets often confused with adenoviruses, which are more pathogenic double-stranded DNA viruses. This unique viral particle is quite simple. It's composed of 3 viral proteins, and the genome inside, I'll show you in just a minute. One of the really innovative discoveries in the past 20 years was the finding that many serotypes of AAV exist in nature and have differential tropism for tissues. And in this case, both it's very relevant to delivering AAV through the bloodstream to reach muscle and the central nervous system. And just to put it in perspective, there are only 2 AAV products that have been approved by the FDA, one for an ocular indication called Leber congenital amaurosis, that was just approved 2 years ago, and then just this past year, the approval of Zolgensma, which is used for spinal muscular atrophy. So the benefit of this is that we know it can persist long term, and as Arnold pointed out, this adds a second page outside of the cookbook, but we have to think about the fact that there are risks and potential benefits with such a therapy, but right now the evidence is that the benefit outweighs the risk, but I'll comment particularly as part of this discussion on the unique nature of high-dose therapy and that what was an inherently non-pathogenic virus in nature actually has consequences when delivered at high dose systemically to treat a disease. So this is again what the outside of the AAV vector looks like. Inside, there is a functional gene that is driven by a regulatory element that's called a promoter. And the only parts of the AAV that stick around are these packaging signals that are so-called internal inverted terminal repeats. They are used to put the viral genome inside the capsid. When it's injected into the bloodstream, it travels to the cell surface, right here where it binds to a specific receptor, travels inside, kind of like the enzyme replacement therapy does, but through that same pathway, in fact, but ultimately reaches the nucleus instead of the lysosome, and there it drops off this extra copy of the functional gene. So you've heard a little bit about antibodies, both to the enzyme itself, and in this case, the antibodies against AAV are very relevant. And so what are they? Well, antibodies are why ants don't get sick. They have little antibodies. Take a minute to take that in. Allison, you get it? Okay. Even works in New Zealand. So this is what an antibody actually looks like. It's a complex protein that's made specifically to protect us from infection against agents like viruses. And in this case, imagine this red structure here is the virus. A unique variable region on the antibody binds to the viral surface and can remove it from the circulation. And we know when you're first exposed to something, and this is why immunizations are given multiple times, because on the second exposure, you can get a higher response. And Dwight mentioned that how the presence of these antibodies are a reason patients are not included in studies of AAV-mediated gene therapy. And much like has been known about the antibodies against ERT, one can have very high sustained antibodies that would prevent inclusion in a study, but there are potential to, with those with lower levels of antibodies, to provide a treatment which would allow them to be included in a study, or in this case, the third subject here in the green line, has a low antibody titer to begin with. And right now, only these individuals are included in gene therapy trials, and about half of adults are actually have evidence of prior exposure to one or more types of AAV, and this pre-immunity, as it's called, is an exclusion for most studies. So we wanted to know is what's the threshold? Is that appropriate? What's the most effective regimen to decrease the levels of antibodies, and what level precludes treatment? So there are a number of studies we've done to actually show that antibodies can mitigate the effect of AAV, and that there are treatment regimens to reduce the impact to be included in studies. So will AAV treatment be effective for the whole lifespan? Maybe, if the target is neurons, but in cells that divide, again, as Dr. Reusser pointed out, when the copy of the AAV sits outside the nucleus, it's not passed on to daughter cells, so that makes early exposure likely to be less durable, particularly in muscle. So we did this experiment in newborn primates. When at 1 month of age, you give an AAV vector, you can actually given at birth, and at 1 month we did a muscle biopsy, and you see very high levels that actually peak by 2 months of age, and as the animal grows about 3 times its birth weight over the first year, you see a progressive decline in the copy number in muscle. It still is above a level that's detectable at 1 year, but you see this tremendous level of dilution would be a problem for newborn therapy with a gene transfer if there's an expectation that it would be sustained a lifetime. And this is also especially true for liver-directed gene therapy where the liver grows dramatically in the first year of life. So what can we do about that? We undertook this study, again, with the support of the NIH, and this is the basis for a study being done at the NIH, to see whether primary antibody formation, how it affects the AAV vector clearance and its efficacy, and whether we can block the antibody formation to allow for redosing of the vectors. And this is a consideration in all pediatric patients because of growth and muscle regeneration. We first came across this conceptually when we did a study in children who received an AAV1 gene therapy, and 3 of the 9 patients were receiving immune modulation because of their CRIM status. And you can see that the AAV1 antibody level in all 6 patients who had no immune modulation had significant increase from baseline. This is the population 2 standard deviations above the population mean. And those that were concomitantly treated for their CRIM negative status, for their continued ERT, remained naive to AAV throughout the year of the study. So we wanted to know whether this combination of drug therapy or pre-treatment could be used in the context of a systemic delivery. That was an intramuscular delivery of the AAV. And so we did this study in non-human primates where they either got no AAV at all, the vector without any immune modulation in one leg, or not the other, so a single dose in this green example, or the same with immune modulation, this group, and you can see that the effect is greater when the immune modulation prevents the clearance of the vector. When you give the AAV once and then a second time without immune modulation, there's an additional stimulus to the immune system, and you can see what should have been at this level, in fact, is lost because the second exposure helps the immune system find the AAV that was present in the first dose and eliminate the expression. When you give the immune modulation and give the vector twice, you can see that you get actually also this same augmented effect and successfully deliver the second time compared to that example. And so we took this experiment on to patients. These are adult patients with Pompe disease who received a local dose of the AAV vector twice in a blinded fashion in both legs. And so this is after both exposures. 3 months after the second exposure, we looked at the antibody levels against the vector itself. And this is the control from the human data that I just showed you, the AAV1 example. And then we looked at antibodies against GAA, and they both remain negative now throughout the course of this study. So there are 3 patients enrolled in this study that have been really important to prepare us to do the similar study in children at the NIH, where they'll receive this same regimen but receive a systemic dose of AAV designed to treat the effects throughout the body. So next question. Can AAV antibodies be reduced to allow for entry into a gene therapy study? And the good news is we do believe that is yes. And we're about to start a study with pre-immune individuals in the Duchenne population. And this was the way we went about this. We gave just the outside part of the AAV without the genome. In the first week, allowed the antibody levels to go up. At week 4, we began the immune suppression regimen and then gave a second exposure of AAV to test the response throughout week 12. And we found that actually this is the pre-immunized level. If you don't give any vector at all, there's no antibody against AAV. But the same drug regimen we were using for the preventative treatment actually also helps lower the antibody level over time in the patients who are pre-immunized. And so we'll see whether this plus other agents are necessary, but this is a study that's about to start, again, not in Pompe, but in Duchenne dystrophy. So just now to move on to the second part, I just want to recap those first 4 questions. That management of the anti-capsid immune response is really important, both in the primary response if you've never had AAV before, or if you've been previously exposed and need to lower the antibody levels over time. This helps us address pre-immunity in the adult population because about half of patients this therapeutic strategy would not be available without this therapy. And it enables early treatment, which is going to be especially important with newborn screening. And this is something to consider with liver-directed gene therapy in children as well because of the growth anticipated in the liver. So I'll spend my last few minutes on this last question: why is CNS-directed gene therapy important in Pompe disease? This has required us to go back and redevelop some of the models that more accurately reflect the human situation. So we all know about the utility of the mouse model that Nina generated in 1998. We went ahead and also did a tailend-mediated knockout of GAA in the rat, and we also have a version now that's a CRISPR model that also knocks in the IVS1 mutation that's common in adults. And then we have purposely bred the carriers of the null mutation in the canine model that's found in Finland in order to see in a larger animal whether we can rescue the treatment. And I'm happy to say we don't have any dogs that are sacrificed as part of this because we found that they can be successfully treated early and maintain essentially a normal outcome clinically. So it's really rewarding to see that, you know, the severe weakness in the untreated animals is very reminiscent of the early onset infantile disease, and unlike the mice, they would otherwise not survive. It's helped us also understand more about the pathology in the brain and spinal cord, because they really both the nerve itself and the neuromuscular junction where the signals are transmitted to the muscle are impacted in Pompe. And there are several studies we've done to show that, and I'm just going to show a couple of those in the interest of time, particularly very profound in the rat model. If we stimulate the animals with increased carbon dioxide to cause the breathing rate to go up, you can see that a challenge of CO2 in an unaffected animal causes the nerve to really be activated to stimulate the diaphragm more. And so these are both the integrated and raw signals in an unaffected rat. When you look in the Pompe animal, they're really non-responsive to the challenge. So this is one of the reasons why there's such extensive sleep disordered breathing in Pompe, because increased CO2, any form of obstruction or hypopnea, is not countered by an increased output of the nerve. And we know why, because if we look in the spinal cord, you can see the lower motor neurons in the Pompe animal are very abnormal. And in fact, I'll show you in a moment, in autopsy samples, in some cases in the phrenic motor pool that controls the nerve, they're completely absent. So it was said yesterday that the phrenic nerve is not involved in Pompe. That is just not true based on the evidence that we have. In fact, if you look at an important measure of nerve function, the power, the output of the nerve, you can see wild type power is shown in this green shaded area, and there's almost no output in the Pompe animal, and that's shown here in the burst amplitude average across a number of animals. So we know this very carefully evaluated in the canine model and the human autopsy. So this is from the lumbar cord, and as I said, in the phrenic motor pool, these neurons are almost completely gone by later in life. So the take-homes from this part is that we know that AAV is going to be a very valuable tool in treating neuromuscular disease, and it has to be made in sufficient quantity as a commercial supply is needed for adult-sized patients. Is going to be challenging, because right now the only commercial supply is for infants with SMA, and that we can prevent anti-AAV antibodies. Early exposure is less durable, but the primary immune response can be blocked, allowing it to be re-administered, and that this pre-existing antibody is potentially will be managed in human patients, and that CNS-directed gene therapy should be considered because of these aspects are an important cause of the weakness in Pompe. So when we started working on this almost 20 years ago, I thought it would be a simple path to follow. We didn't really know about the other types of AAV at the time, so we've had really some learning from that, some hills to cross and valleys to climb, but I think we're getting closer, and I just say thanks to all the group at Florida who's been working on this project, and to our sponsors both at the NIH, NICHD, and NHLBI, as well as the NIH team that will be conducting the trial in infants starting early in 2020. So I'll end there. Thanks.
Thank you very much.